Good, a- good afternoon, everyone. Thank you so much for the ISOP for inviting me to present in the ISOP Patient Safety Day 2024. I would like to thank you for this great opportunity. My name is Dr. Azeez Al-Jumaili. I'm a faculty member at the University of Baghdad College of Pharmacy. I'm also a national expert at the WHO regarding the AMR. I conducted the AMR report in 2023 in collaboration with the Iraqi Minister of Health and the WHO. Today, I will talk about antimicrobial resistance in Iraq. It's really an important topic, as you know. So today, I will try to talk about the antimicrobial resistant surveillance and stewardship in general. Also, I will talk about the Iraqi situations according to the situation analysis 2023. I will brief about the literature review in Iraq. So as you know, antibiotics developed early in the 19th century with the penicillins. Then, unfortunately, after a few years of use, the antibiotic resistance developed. So as you know, in 2015, we had the last antibiotics, ceftolazone and tazobactam. And unfortunately, in 2020, we had the resistant emerge. So even the companies took many years and billions of dollars to develop one antibiotics. After a few years, this antibiotic may be not effective anymore due to the abuse and misuse of antibiotic. So when we say antimicrobial, it's any agents can kill or inhibit the growth of microorganisms such as antibiotics, antiviral, antifungals. But in general, when we talk antibiotics, we mean the antimicrobials. We mean the antibacterials. So we use antibacterials mostly in the infections to kill the bacteria. Kill the bacteria mean they are not effective against the viral. This is the major misuse in Iraq. People use antibiotics against viral infection. So what do you mean by bacterial resistance or antimicrobial resistance mean this antimicrobial is not effective anymore. So ineffective mean patient with this germs may die due to infection. Imagine we have serious infection at the hospitals and the available antibiotics are not working against those germs. So antimicrobial resistance is really global threats. According to the WHO, it's one of the top 10 global public health threats for the humanity. And there is a good chance we go back before the developing of antimicrobials. So threatening to the humanity, this serious issue. That's why we present here. We do situation analysis. We need action. We need to stop the spreading of antimicrobial resistance because we need our weapons against bacteria. If we don't have effective antibiotics, these bacteria may kill patients. So there are statistics about 5 million people death worldwide in 2019. We have multi-drug resistant bacteria, or we called also pan-resistant bacteria, which is superbugs. Pan-resistant bacteria, they are not treatable. They are resistant to any antibiotics. So if you ask me why we care about antimicrobial, we care because it's a serious issue. We care because it's increase the length of hospitalization. It may cause treatment failure, increase significant human suffering, may lead to even death, in addition to the economic burden on the society and the Minister of Health and the families. So it's really serious issue. Human lives at risk, millions of dollars may lost. Statistics say more than 700,000 people die annually due to antimicrobial resistance, and there's expectation to become 10 million people die annually in 2050 if we don't solve this issue. So high risk, it's alarming threat. Why we have antimicrobial resistance? Because we overuse antibiotics. We have poor infection and disease control. We have poor access to good quality of antibiotics and vaccine. We have lack of awareness among general population and even some healthcare providers. And the most important things, lack of enforcement. We have the laws, but we have lack of enforcement of these laws. So what are the 5 objectives of the Global Action Plan? We need to raise awareness, strengthen surveillance and research, reduce incidence of infections, optimize use of antimicrobials, and ensure sustainable supply of antimicrobial. So imagine we don't have effective antibiotics and we don't have new antibiotics. So if we have pan-resistant bacteria, no effective antibiotics, this patient will die due to infection. So the surveillance is the first step to increase the awareness of healthcare providers and the health authorities about the current infections, the current situations. If we don't have surveillance, we don't have data, we don't have information, we don't have statistics. So it's very important to have effective AMR surveillance, which is good in Iraq. We have it in collaboration between the Ministry of Health and the World Health Organization. But unfortunately, till recently, it's limited only at the governmental healthcare settings, not the private sectors. Because in Iraq, we have private sectors and we have public sectors. Public sectors governmental run. Private sectors usually not governed by the governments. Usually, healthcare providers work independently. So the good news, if we have good surveillance, that's mean we can get good antimicrobial treatment guideline. We can inform the prescribers. Even the empirical prescriptions will be more accurate. So WHO help low and middle income countries to have good reporting systems and developed HONET, WHO net system to report the culture and sensitivity test. And we have global system of glass AMR, more than 9 countries involved in this system in collaboration with the WHO. So developed country, they are in better shape or better situation than the low-income countries, because low-income countries, they have less resources, less awareness, less enforcements, more resistance, emerging of resistance. As you know, we have WHO say we have one health. The globe, we have it's a global issue. One patient from low-income country with high resistant bacteria may travel to a country, developed country, and the resistance may transfer from one patient to another. The good things, Iraq is one of those 9 countries involved in the glass, and we have involved in both AMR and antimicrobial consumption and antimicrobial stewardship. So Iraq has already member at the WHO regarding to the glass AMR and the glass AMC, and according to the Minister of Health data and WHO data as well. So there is global action plan helped by the WHO to control emerging of resistance. So WHO try to help low-income country to enhance their surveillance, enhance their stewardship, but they cannot enforce law in their countries. So they guide us, they give us recommendations, and we need to implement these recommendations on the ground, on the healthcare settings. So first of all, we need to identify the situation as we done in 2023 in the collaboration with between the WHO and the Minister of Health. Next step is to implement these recommendations. Okay, we know now these recommendations, we need to work. So what's the AMR surveillance in Iraq? In Iraq, we started officially with the AMR surveillance system with the WHO in 2019. We have the focal point at the Public Health Directorate at the Minister of Health. We call it the AMR unit with Dr. Rana Abdelmehdi now. It's as a director of this unit. And she helped me to prepare the situation analysis report, AMR in Iraq in 2023. So we have good surveillance system. We have report 2020, 21, 22, and I will summarize the 2022 report by the Minister of Health here in this presentations. So the good things, we have WHO net, we call it HONET system. It's all the 73 labs and 73 public hospital report their information to the headquarters of the Minister of Health, especially the Central National Lab in Baghdad. So I would like to thank the AMR section and the Minister of Health for providing me for these figures and statistics from the national report about the AMR in Iraq in 2022. As you can see, it started earlier in 2017, but the surveillance became more advanced with the time, especially with the help of WHO and HONET, using HONET by the public hospitals. So the lab at the public hospital use this software to report culture and sensitivity tests to the central lab in Iraq, and this information collected and the national annual report prepared by the Minister of Health and published at the Minister of Health website. So Iraq focal point, Directorate of Public Health, responsible for the surveillance, while the Directorate of Technical Affairs, responsible for the antimicrobial stewardship. So we have two directorates, two entities within the Ministry of Health. One is responsible for antimicrobial surveillance. Second one responsible for the antimicrobial stewardship, which is the clinical pharmacy department at the Directorate of Technical Affairs. So we have 72 surveillance sites and 72 public hospital in 11 provinces across the country using HONET software. Thank you for the WHO for training Iraqi lab staff, central lab staff about this HONET, and the staffs usually train the lab staff at the provinces. And the last training happened at the Kurdistan region in collaboration between the WHO and Iraq Ministry of Health and Kurdistan region. So HONET is really helpful, and thank you for WHO to provide it to us and to more than 130 countries worldwide, and include it could be in 44 languages, and we usually use the English version in Iraq. So this is the example of the HONET softwares about the result of culture and sensitivity test which is good to identify any outbreaks and collected these accumulative data. But usually they transfer data offline, not online. We still need to do it online. So the results I got from the Ministry of Health, they have alarming data results about the high rate of resistance, such as resistance rate to Acinetobacter up to 70%. Acinetobacter has multi-drug resistant and 67% extended day resistant and 32% pan-drug resistant. Imagine third of Acinetobacter infections, there is no antibiotic work against them. Third of infections. So as you can see the table, high rate of resistance. So the results of the surveillance, they could give us the results. The results say we have alarming rate of resistance. What should we do? These results from the public hospitals, as well as from public hospitals, even we have antimicrobial stewardship in public hospital, we still have high resistance because the private sector is still not under control. We have I will explain this in the next few slides. Show alarming results. As you can see here, also the cefotaxime, ceftriaxones, we have resistant Escherichia coli, resistant to third generation cephalosporin in 75% of cases. Imagine 3/4 of cases of infections, we have resistant against third generation cephalosporin. So the news is not optimistic. High rate of resistance against third generation cephalosporin. We have only 2 antibiotic left against those bacteria. Meropenem, vancomycin, mostly antibiotic stewardship focus on the meropenem and vancomycin because the third generation cephalosporin mostly prescribed empirically by the Iraqi healthcare provider and prescribers. Empirically without culture and sensitivity test, even they are under the watch list of the WHO. As you can see in this figure, high rate of resistance, and we only left with the few antibiotic effective such as levofloxacin and vancomycin. That's why the clinical pharmacy department tried to focus on the use of those 2 antibiotics. Unfortunately, third generation cephalosporin, due to empirical prescribing, self-medications, 75% of cases resistant to those antibiotics. So we lost the third generation cephalosporin effectiveness. What should we do? We need to enforce the antibiotic stewardship, not only in the public sector, also in the private sector. In Iraq, we have a few, not more than 5 reserve antibiotics, and they are used only in severe cases, as you know. As you know, we have high rate of adverse drug reactions due to those reserve group, such as colistin, tigecycline, and linezolid. So they are only used for life-threatening cases, such as pan-drug resistant cases. So what's the current situation of antibiotic stewardship? In general, antibiotic stewardship means enhance the prescribing and enhance the use. Prescribing by healthcare provider, use by patients. So we need to improve the prescribing behavior and the use behavior. So in general, WHO classify the antibiotic into 3 categories: excess, watch, reserve. Green, excess is green. It can be used because it's narrow spectrum antibiotic, can be used safely. Watch antibiotic It's for the more complicated cases, and the reserve antibiotic as the last choice. So it's a red color, few of them, while most antibiotic used in Iraq now under the watch list. These are some examples from the WHO, such as penicillins or the excess one. Watch antibiotic, third generation cephalosporin under the watch list, the yellow color. We have high rate of resistance to third generation cephalosporin. Colistin and linezolab under the reserve list. We have 5 of them in Iraq, 2 in the public sector, 3 in the private sector. Action plan, there is a global action plan by WHO. They are helping low-income country to control antibiotic resistance. High developed countries such as the US, they have good systems of enforcement, good system of stewardship, and they got good results. As you can see in the CDC report in 2019, they reduced the resistance of most bacteria. 40%, 21%, 33% reducing in the resistant. Good news. That means we can do it. If you follow this good example of antibiotic stewardship, enforcement, we can reach their point. Not yet. We are working toward this target, but there is slow progress in Iraq. The current situation of antibiotic stewardship in Iraq, in general, we have antibiotic stewardship at the public hospital. Clinical pharmacy program doing well in the public hospital, but unfortunately, we don't have it at the private sector. Private sectors mean physician prescribe antibiotic empirically without culture sensitivity test mostly. Community pharmacies may dispense antibiotic without prescriptions. That means patients may ask for antibiotic for their flu. They may get antibiotic without prescription, self-medications, misuse, antibiotic used for viral infection. So we really have uncontrolled situation in the private sector. We have it in the pharmacy law. Antibiotics should not dispense without prescription. Unfortunately, we don't have enforcement. We don't have electronic system. We don't have control over this stock. Still, we have dispensing of antibiotics without prescriptions. This is the reality. Clinical pharmacy doing well since 2014 at the public hospitals, but still there is not enough enforcement of the prescribers, because at the beginning there is stewardship committee including clinical pharmacist, surgeon, microbiologist. 2019 added manager of the hospitals and the infection prevention and control members and a nurse. Still, we didn't reach 100%, but still we have partial implementation of stewardship at the public hospitals. So clinical pharmacists ask physician to have culture sensitivity tests, especially for the vancomycin and meropenem and levofloxacin. So these 3 antibiotics usually under restrictions, while third generation cephalosporin usually prescribed without culture and sensitivity tests. Iraqi National Board for Drug Selections, they usually approved the new medications in Iraq. We have 13 antibiotics under the excess list, 17 antibiotic under the watch list of antibiotics, and 16 anti-TB, anti-tuberculosis, and we have only 5 preserved antibiotics in Iraq. Only 5, 2 in the public sectors and 3 at the private sectors. So high rate of infections, low reserve antibiotics. Even in animal studies, I would like to thank the Ministry of Agriculture for providing us, Dr. Wael, as the AMR unit, providing us with a list of antibiotic surveillance systems in the first year of 2023. So in the law, the antibiotics cannot be used as growth promoters in the animals, but still these laws are not enforced. And as you can see, we have high rate of resistance even in animals. Those are isolated from animals in the first half of 2023. And high rate of resistance. These resistant bacteria can transfer from animal to human. So summary of literature review I conducted, I found more than 37 studies, and I will publish this soon in the WHO Mediterranean journal. In general, we have empirical prescribing of antibiotics. We have dispensing antibiotic without prescriptions. We have misuse and overuse of self-medications of antibiotic by the general populations. We have even trace or residual of antibiotic in the drinking water and the raw beef. So antibiotics are everywhere. They are not under control. We have high resistant bacteria. Those studies give us this summary. Even some antibiotics used as a growth promoter for animals. High prevalence of resistant. So the news is not that optimistic, but we are working hard at the Ministry of Health in collaboration with WHO to control the situation at the public sectors, but still the private sector need more attention. So 37 studies, all these say we have misuse, self-medications, and awareness, low awareness level by even some of medical students and general population. Even they found resistant bacteria in the water. In conclusion of our situational report, AMR situation report in Iraq 2023, we have empirical prescribing of antibiotics at the public and private sectors. We have dispensing antibiotic at the private sectors. We have partial implementation of antibiotic stewardship at the public sectors. We have good IMR surveillance systems at the public sectors. Public sectors are is better than the private in terms of surveillance, in terms of stewardship, because there is the focus of the Ministry of Health on the public settings, while private settings still not that controlled. We have self-medications by general populations of antibiotic. Found some residual in the drinking water, in the beef, even the market and some beef. That's mean those used as growth promoters in animals. Even the bacteria isolated from animals, they have high resistance. So recommendations, we need more collaboration between Ministry of Health, Ministry of Agriculture, and other ministries to minimize the emerging of bacterial resistance, because we don't want to reach to the situation when we don't have antibiotic to treat life-threatening infections. We need to test the antibiotic residuals in the water and in the meat. We need to enforce not dispense antibiotic without prescriptions, not use antibiotic as a growth promoter for animals. We need more law enforcement, more control. I would like to thank my collaborators, Dr. Anana Abdelmehdi from the Iraqi Ministry of Health, Directorate of Public Health, IMR unit, Dr. Haidar Jawadi from the Ministry of Health, Directorate of Technical Affairs, Clinical Pharmacy Department, and Dr. Abdurrahman from WHO Iraq office, Dr. Amr Baban also WHO Iraq office, and Dr. Wael from the Iraqi Ministry of Agriculture, AMR units. They helped me to summarize the situation analysis of Iraqi AMR. Thank you. Also, I'm ready to receive any questions. Again, thank you for the ISOP for inviting me. This is my email. Thank you again. I'm ready to answer any question. Thank you very much. And hope I summarized everything about the AMR in Iraq for you. Have a good day.